Welcome, everyone, and thank you for joining us today for part 2 of our 3-part webinar series, Exploring Hospital and Physician Dynamics, Primer on Medical Staff Adverse Actions. My name is Alex Keoskey. I'm a partner here at Frier Levitt. As a healthcare attorney for the last 28 years, I defend physicians, physician groups, and healthcare providers of every type against adverse actions brought by hospital medical staff, licensing boards, federal and state regulatory agencies, and third-party payers. Previously, I spent 20 years as a Deputy Chief Compliance Officer for a federally qualified health center and 6 years as a Deputy Attorney General for the New Jersey Division of Law, prosecuting on behalf of the state's healthcare licensing boards. I'm joined by my colleague today, Todd Brower. Todd, if you could introduce yourself, please.
Sure. Thanks, Alex. My name is Todd Brower. I'm part of the Frier Levitt Healthcare Group. Prior to joining the firm last fall, I had been in-house as general counsel for the St. Joseph's Healthcare Center. And prior to that, spent about 31 plus years in private practice representing hospitals, physician groups, medical staffs, and other healthcare providers. And while my experience kind of ranges across all sorts of matters addressed and affecting healthcare providers, I've spent a good part of my career representing and advising hospitals and medical staffs on dealing with corrective action with physicians, which obviously is the topic of this webinar series. Alex?
Thank you, Todd. Much appreciated. We're going today to cover topics. We have covered topics, and we're going to cover several more. The importance of civility, the adverse actions on professional records. This particular slideshow we're going to do today talks about civility and communication, which is a very, very important component of adverse actions at hospitals. Today's presentation will be an in-depth discussion on actions brought against so-called disruptive physicians, quote unquote, which we see a lot in bylaws in hospitals. So this webinar will be recorded. You will receive a link to view the webinar on demand. After the presentation, you can send us questions using the Q&A tab on your screen or during the presentation. And these questions are private, so only be seen by the presenters. We'll answer as many questions as we can before the end of the presentation. If you would like to ask questions at a later date, you could feel free to do so as well. That will not be a problem. You can do that also. And by the way, we will also have Todd's linked information and my linked contact information, phone, and also email for you if you'd like to get a hold of us later on and ask us. Just by way of disclaimer, the materials and the information provided in this presentation are for informational purposes only and not for the purpose of providing legal advice. The information contained in this presentation is a brief overview and should not be construed as legal advice or an exhaustive coverage of the topics. Part 3 of this series for your calendar is going to be scheduled for July 10th. We'll cover adverse action reporting, the consequences of a permanent record, another very important topic. So let us get started. First, we'll talk about Frier Levitt, and this is from our website. We are a national boutique law firm focused exclusively on healthcare and life sciences for healthcare and life science providers. Firm draws an experience representing stakeholders across the entire healthcare spectrum. Please check our website when you can. And this is the information for you, for Todd and I, to get hold of us with regard to any questions you may have. Now we will talk about civility and communication. There's an old saying you may have heard from your grandparents. It's nice to be important, but it's more important to be nice. For any professional, one of the best skills you can achieve, besides the background training and education you get professionally in your area of practice, is to be what we call diligently self-aware with regard to how people perceive you and how you get along with others. The manner in which one speaks, discusses, leads, or collaborates in a healthcare environment can really today make or break their professional career. This is a skill. It's a skill set. It has to be learned over and over every day for any professional. And one of the keys to staying out of trouble in the workplace is to stay current regarding what we will call the current legal standards of behavior and communication. Many of you know there's been lots of paradigm shifts in healthcare. The paradigm shift that occurred generations ago was, of course, the advent of managed care. About a generation ago, the new paradigm was the absorption of medical practices by large hospital systems and the consolidation of large hospital systems made up of smaller, previously private and independent hospitals. The big paradigm shift today is the change of tolerance regarding behavior in the workplace. What was acceptable workplace behavior even 10 years ago is no longer tolerated. In fact, it can result in discipline or a lawsuit in which you're named as a defendant. So an angry disposition, harsh words, shouting in the clinical workplace, throwing things, you may have gotten used to that if you're old enough when you were a resident, but today it's considered to be what the bylaws will refer to, and I'm quoting here, many bylaws have this language, detrimental to patient safety or to the delivery of patient care, or harassing or intimidating to staff and colleagues, patients, or their families. And this subjects the offender to discipline. So it's really, really important to get a whole handle on that and understand what is tolerated and what is not. We're going to talk about what type of actions are brought. What are the issues with disruptive physicians? Obviously, enabling is one of them, right? The same individual who's allowed to have this type of behavior pattern and demeanor and is accepted, maybe because they're in leadership positions, maybe because they've been around a long time, maybe because they don't have a very compliant workplace. That's one issue. The other is morale, and that's a big issue. Today, because people no longer tolerate this type of harassing behavior or disruptive behavior, morality, moral, the morale of your work staff and your colleagues is going to plummet when they know they have to come to work every day and face this type of behavior. It's obviously a compliance issue. It's a big compliance issue because now being a good person and being somebody who behaves at work, gets along with their colleagues, communicates well, and is civil, is being a compliant individual, where years ago that you could be someone who was not very good and not very well behaved and not have great demeanor and be angry. And people would say, well, that's just the way they are. It really doesn't work anymore. Risk management liability. Obviously, this type of behavior can lead to actions of all type. Can lead to adverse actions against the provider themselves. It can lead to actions by ancillary medical staff and others against the hospital, against you, in lawsuits. And it could obviously lead to actions against the hospital in general if patients catch wind of this and they feel that their care has been affected by it. And of course, patient safety. We're going to talk about this, but communication is key. But there's an article from the AMA Journal of Ethics that says that teamwork failures in communication account for 70 to 80% of serious medical errors and a contributory factor in 61% of sentinel events. That's pretty significant. Other similar studies have demonstrated that poor teamwork causes a host of serious issues, including but not limited to a burnout, as I said before, poor morale and system inefficiency. So this is a fact. This has been documented, and this is why they include this type of language in the bylaws, and this is also why it's actionable today. We say that disruptive behavior exists on a continuum. So it's general temperamental behavior requiring a measure of intervention. In other words, where it gets so bad and it's no longer tolerated, people complain and exposes the hospital again to legal and regulatory scrutiny. And Todd and I see this over and over again. It is really what we call in the law the flavor of the month. It's something that's just come about and has to be addressed. Some of the causes of disruptive behavior that are pretty significant: personality, culture, upbringing. We don't just refer to culture as, ethic or religious culture or that type of background, but the culture of where you come from, where you were raised, even in the United States, or the culture of whatever background you have in your professional career. You may have worked in high-risk areas and high-stress areas where this type of shouting and screaming was normal, and you think that normality can be placed anywhere, and it cannot. There's behavior, health, stress issues, and a lot of these stress issues come not so much from the workplace, but some other things that are going on in the provider's life. In other words, if have a stressful home life, you have issues that are going on in your life, whatever that may be, that you're bringing into the workplace. Impairment might be a real impairment with regard to civility and behavior, and that's why we have courses and other things that deal with that and help you gain the skill to sort of, adopt what's called the 10-second rule and an ethical standpoint that makes you understand that shouting and screaming and a bad demeanor is not compatible with the workplace. Ego is a big thing, right? People that have a lot of pride and want things their way. Leadership style. If you're a professional today, you inevitably have encountered somebody who thinks the leadership style by being aggressive and being the boss and being in charge is much more important than collaboration. And then, of course, turf wars. We've all seen that, and that is physicians that are competitive in one way or another for whatever reason can cause these type of things. These are the types of disruptive behavior that are self-explanatory, but it gives you a kind of outline of what is no longer tolerated and what is actionable in the healthcare workplace. So with that, take a look at that, and I'm sure most of you have seen this type of behavior in one form or another somewhere in healthcare if you practice long enough. But note that these type of behavior patterns are absolutely actionable, and they can cause you to get removed from a hospital staff. And Todd, you can take it over from here. Thanks.
Okay, thanks, Alex. Okay, it's interesting. I think disruptive behavior situations are more challenging than quality of care situations. Basically, in quality of care issues with physicians, there's been a bad outcome. There's an event to look at, and there's something to evaluate. When we're talking about disruptive behavior, we're talking about behavior that's on a continuum, as Alex talked about, and we don't have, to put it crudely, we don't have the dead body yet, but there's the potential for that. There's the potential for an adverse event. And how bad is bad enough that we need to take corrective action? Regardless of where the behavior falls on that continuum, however, you have to act for a number of reasons. And first of all, you can subject yourselves at an institution, a healthcare facility. This would apply even to a physician practice in many cases. You subject yourself to potential liability. Claims are brought for intentional infliction of emotional distress. It's where someone acts recklessly or intentionally to cause severe stress on another individual that creates emotional or physical harm. Hostile work environment. Every facility has HR policies that deal with the issue of a hostile work environment, and that's where a situation may be that a physician is berating a nurse or a technician or someone else, and they go to HR. If HR doesn't address it, and HR in most cases is going to want to address it, it will result in a lawsuit and potential civil liability. The same thing with discrimination claims. Some people think that if a physician who's not an employee of the hospital, but just a member of the medical staff engages in kind of disruptive behavior that would include things that are prohibited under the law against discrimination, excuse me, can't, a lawsuit can't be brought, but it can. Even a volunteer member of the medical staff who engages in this behavior can cause a suit to be filed against the hospital or healthcare facility. And of course, there's also the corporate liability. We talked a little bit about this in the first webinar. We're seeing more and more of this. You have a physician on staff who's engaged in disruptive behavior over a long period of time, and the hospital never addressed it. And then the bad event happens. We end up with the dead body, as we say. And what happens then is someone sues for negligent credentialing because you had noticed, you knew the physician wasn't good, and yet you did nothing about it. So it really comes down to being a risk management issue. The disruptive behavior can clearly create a negative impact on patient care, and it increases the greater risk of errors due to stress and low morale. It leads to demoralized staff, absenteeism, retention issues. When I was at St. Joseph's Health during the COVID crisis, I was just absolutely amazed at how healthcare workers really rose to the occasion, how people stepped up and did an amazing job and really put themselves and their families at risk rendering care. But as the COVID crisis subsided, you began to see the burnout. You began to see the post-traumatic stress syndrome type of situations where people were really, really tired and stressed out. When you have, and that applied to physicians as well, of course, but when you have the disruptive behavior by physician now, they're dealing with a group of employees who really already are suffering post-COVID. And that leads to losing staff, which is anybody knows in this business, in hospitals in particular, they're always struggling for nursing and other types of practitioners as well. It also can lead to poor ratings and reputation. Hospitals love all the rating agencies and surveys and what have you when they get good scores. All you have to do is drive up and down the highway and see the billboards with the hospitals touting their scores, either from Leapfrog, from GuideStar, from US News and World Report ranking of hospitals. It's really important. And those surveys and ratings will get to issues of where there's low morale and where there are issues within the facility among the staff because of disruptive behavior. And then there's always regulatory scrutiny. It's interesting that people become more and more sophisticated. They know how to complain to the BME, the Board of Medical Examiners. They know how to complain to the Department of Health. And when they get these complaints, you open yourselves up to a regulatory investigation, which nobody wants, because as you know, when the Board of Medical Examiners or the Department of Health comes into your hospital, they don't come in just to look at the one complaint. They come in and start looking at everything. And another issue that probably should be listed on here is union activity. I have, and Alex, I'm sure you have as well, encountered situation in cases of disruptive behavior where a physician has acted out towards nurses or other people that I sit there and I wonder if, in a hospital where there may not be a union, this would initiate a union drive if a union had this information. Even if they have a union, it's the kind of information unions will want because they'll be able to use it against the hospital or the healthcare facility during negotiations or other times. So there's a lot of risk involved in dealing with these issues of disruptive physicians. But beyond the exposure to civil cases, beyond the things we just mentioned on the previous slide, you also have legal duties to act, and those duties are found not only in the hospital and medical staff bylaws, but also in various state and federal laws and regulations, as well as common law. Again, the law against discrimination can apply and actually govern how you need to deal with these situations. The civil cases that we talked about previously, a court decision can very well define the standard you must meet. And we'll talk a little bit about that when we talk about the Nanavani case. Medicare conditions of participation, Joint Commission standards deal with this, and we're going to go through some of that. Some hospitals are moving. I know when I was at St. Joseph's Health, we used DNV as our accreditation agency as an alternative. It's actually a great agency. I try to pronounce what DNV stands for, but it's Norwegian, so I don't even want to attempt. 7.5 years, I never really learned how to say it right. Then there's the AMA Code of Conduct. You have state licensing laws and regulations, including, the Healthcare Professional Responsibility and Reporting Act, which you need to comply with when you're dealing in these situations, all of which may apply. So if you look at bylaws, all hospital bylaws, medical staff bylaws, they're going to have this kind of standard set forth in the bylaws that where conduct is going to be so disruptive to the operations of the hospital, corrective action may be warranted. This is a good example of a standard that should be in the bylaws. But what's key, and I think a lot of healthcare facilities have done this, if they haven't, they need to do this, is you need a policy separate and apart from the bylaws. That policy has to get into the weeds. It has to define what disruptive behavior is. It has to define and outline the process for some type of corrective action in a progressive stages. And it's also important that these policies, it's not just a medical staff policy. It needs input from a lot of people. Obviously, the chief medical officer, who's a Part of administration should be part of it, but nursing needs to be involved. HR needs to be involved. Risk management, legal counsel, because it's very important that these policies have it right, both in the definition and the way corrective action is going to be taken. And the reason we emphasize doing it in a policy as opposed to bylaws is simply because bylaws, as you know, it's a cumbersome process to amend bylaws. You need this type of standard in your bylaws, but a policy, which if it's an administrative policy, is easily amended. If it's a medical staff policy, typically the medical executive committee can approve changes. It gives you that flexibility. So the detail should always be in a policy and not in the bylaws. So let's take a few seconds or a few minutes here to look at the leadership standards set forth by the Joint Commission as an example. It talks about the intimidating, disruptive behaviors, and it talks about disrespect, not limited to outbursts of anger that humiliate a member of the healthcare team. It can manifest in many forms. And again, this is how we get to that continuum of behavior. So what are some examples? Okay, an obvious one that we've probably all encountered. Inappropriate words, profane, insulting, intimidating, demeaning, humiliating, or abusive language. Throughout my career, and Alex, I know you've had this experience as well, the first response usually from a physician who is engaging this kind of conduct is, I'm a perfectionist. I have a low level of tolerance for the incompetency of the people around me, and all I care about is what's in the best interest of my patient. If it's a kind of outlier situation, it's someone who just lost their cool once, it's not something that happens routine. It's still not a good excuse or a defense, but it may not be a problem. The problem is the repeat offenders, the ones who engage in this behavior over and over and over again. And I've been through the experience where someone who's a repeat offender comes back with that defense. I'm a perfectionist. Whenever someone says that to me, that's a red flag. Shaming others for negative outcomes and unjustified negative comments. We'll probably talk a little bit about this later, but this can occur between peers too, among physicians. Trying to, malign other physicians. Refusal to comply with known and generally accepted practice standards, and the refusal of which may prevent other providers from delivering quality care. I'll share with you a story of a case I dealt with many years ago, but it involved an orthopedic surgeon. Excellent surgeon, high quality, high volume producer, liked within the institution. He had a prime block of OR time saved for him because of his productivity. One day, things aren't going well. There's starting to be complications in the cases. Nothing that's resulting in an adverse effect, but it's delaying, and now cases are backing up, and he's getting more and more agitated, and he was known to have a temper. Eventually, a patient is rolled in. The nurse does the timeout. That's where everyone stops. You identify that you have the right patient. You identify what operation you're doing. You identify the right limb, etc. The physician was furious. Everything was delayed. He started screaming at the nurse, "We're not doing the timeout. We don't have time for this. We got to move on. I know what I'm doing." So the nurse presented him on a clipboard a form that the physician's required to sign if he doesn't do the timeout. It's generally supposed to indicate it was an emergency. This enraged the physician, surgeon more. The clipboard went flying. He started screaming at the nurse and eventually threw her against a wall. Now, the medical staff did exactly what they should have done. They summarily suspended him. And I want to share this story because it was a unique experience. Because when that physician was then before the medical executive committee, and first they listened to the nurse, they listened to another witness, then he came in, and I was absolutely impressed. The physician first apologized to all his peers for interrupting their evening. He was embarrassed. He acknowledged what he'd done was totally wrong. He was asking for a leave of absence, and he was going to the physician, the PAP program, physician or practitioner assistant program, to get help in anger management. The sad thing is, that's the only time I've ever seen in my career it handled perfectly. The medical staff did the right thing. The physician did the right thing. Unfortunately, what usually happens, more cases than not, if it's a prominent doctor, if he's politically connected, the hospital will wring its hands what to do. And they'll try to figure out ways to defend the doctor or perhaps save him. Or even if they do a summary suspension, the physician will show up and we get the I'm a perfectionist defense. They'll be very defensive and it deteriorates from there. So I always remember that one case because it unfortunately was the only time I saw it in my career, but it was exactly how it should work. But clearly that orthopedist did something very wrong. He owned it, acknowledged it, and it was dealt with appropriately. Not working collaboratively or cooperatively with other members of the team. Another case I dealt with many years ago at a hospital. It's a Saturday. There's a surgeon. He's doing procedures, and he and the anesthesiologist get in an argument. The patient is under conscious sedation. The argument escalates to the point where they start a fist fight in the OR. It breaks through the doors of the OR. They're now out in the hallway while the rest of the team is in the OR. And they are in a fist fight until another doctor comes along and breaks it up. They call me. To me, this was a clear-cut case of summary suspension, and yet the hospital didn't do it. These were two important doctors on the staff. They were afraid to take the action, and it really sent the wrong message, I felt. Part of their defense was, which is somewhat ironic, is that after this fight was broken up, the two of them, the anesthesiologist and surgeon, went back into the OR and actually did 4 or 5 cases together again without incident. But I said I really didn't think that was enough, that they really needed to address it. I think that's the situation. Also, there were enough people there, saw what happened, that it definitely sent the wrong message. Creating rigid or inflexible barriers to requests for assistance or cooperation. For those of you who've been in the healthcare world for a long time, you can remember long ago the captain of the ship doctrine. I mean, basically, the physician, the surgeon in that OR was viewed as the captain of the ship. Whatever he ordered, you didn't question it, you didn't challenge it, you didn't intervene, even when you knew that something was going wrong. A great book, The Outliers, if anyone's ever read it. There's a whole chapter on South Korean Airlines back in, I believe it was in the 60s. Exact same problem they had. Everybody, the navigator would know the plane is flying into a mountain, would politely try to convince the captain of the pilot to change course. If the pilot refused, literally everyone sat back while the plane flew into the mountain. They broke that culture. They went from one of the worst airlines safety records in the world to one of the best. So it's the same thing here. We've come a long way. More and more we see nurses and others be able to stand up and intervene, but it's still a problem. I have sat through meetings with physicians and nurses and others to go over a specific case where something had gone wrong, and you just watch the level of intimidation from that doctor. I sat through one where the nurse literally just came out when the chair of the department said, "Why didn't you intervene?" And she said, "Dr. So-and-so intimidates me." That's not an excuse for that nurse or anybody else, but you realize it's still a problem, that she did not feel safe intervening and injecting herself or going to get someone else to get help. And there was a very serious bad outcome in that case. So that whole captain of the ship, the intimidating nature of doctors is still a problem. And hospitals and healthcare facilities really need to back up and provide the support for their employees to do the appropriate thing. And then not responding to requests for assistance or information, not returning pages or calls promptly. Probably don't even think of that as disruptive behavior, but it is. It's very important that physicians can be reached. And that can lead to bad outcomes too, as people are waiting for a decision to be made. We also have the American Medical Association opinion, which I think is really good. And here again, they're talking about disruptive behavior, whether it's verbal or physical, that negatively affects or that potentially may negatively affect. And that's what we're talking about. We're not waiting for the adverse event. We're not waiting for the dead body. We've got to take action before something bad happens. Now, this is a good statement. It's a good thing to guide by. But you want your policies, and again, as we talked about before, you want specific policies to deal with this. You want those policies to also specifically reference the legal standard for what is considered disruptive behavior that rises to the level where you can take corrective action. And the reason is if you take corrective action and a physician challenges it, the court's going to hold to that standard. And so that's why it's really important. So that's how we get, as way of example, and of course, depending on what jurisdiction you're in, you need to check your statutes and case law. But in New Jersey's, the case that set the standard was Nanavati versus Burdett Tomlin Memorial Hospital. This is a physician who had a history of being disruptive. There was plenty of evidence, and the hospital went to revoke his privileges. And what the Supreme Court said is that hospital privileges can be revoked due to a physician's inability to work with others. But here's the key. In such situations, hospitals must show that the prospective disharmony will probably have an adverse impact. So that's kind of the standard that your policy should reflect. It should be that it rises to a level that will probably have an adverse effect, not a maybe or potentially. I think it's a slightly higher standard. And they also said in evaluating physicians for staff membership, obviously you can do the same analysis. This case set the standard, but Dr. Nanavati prevailed in that it was determined that his level of conduct didn't really rise to the level where it warranted termination of his privileges. And as an aside, because I always found this kind of interesting, several years after this case, Dr. Nanavati actually became the president of the medical staff at Burdett Tomlin Hospital. Just a couple other cases that I've seen over the years that I think are really illustrative if you have a chance to read them. One is this, I don't know how it's exactly pronounced, Gier case, where basically the Wyoming Supreme Court affirmed the hospital's decision to revoke privileges. His behavior was repeatedly throwing scissors, berating OR team members, and was generally disruptive. The key to this case that comes out, this was going on for over 14 years, and it had never been addressed. So when they finally did address it, obviously they had a lot to do it. I don't know if there were ever bad outcomes resulting from this, but obviously it went on for a long time. And then there's this case from Delaware. And again, it's kind of similar. They upheld the right of a hospital to block, the hospital decision to suspend a staff surgeon for inappropriate behavior. And there he would interrupt doctors' meetings while waving arms wildly, verbally attacking the staff, and a lot of complaints being raised over the years. Waving a drill at an OR team member kind of gets up there as well. So these are the kind of behaviors that we don't have to wait for an adverse effect. We actually can take action in order to avoid that happening in the future. Not easy. It's just not easy to figure out what level rises to that occasion, what level of disruptive behavior arises to that occasion. So what we'd like to put forth here is what we would count as an ounce of prevention. It's important that you adopt a code of conduct. Most hospitals have a code of conduct, but it needs to define acceptable conduct as well as disruptive and inappropriate behaviors. The next key point is educate. You got to let the staff know, the physicians in particular, they need to know what is disruptive behavior and what the consequences will be for disruptive behavior, as well as the rest of the staff, because quite frankly, people may be subject to disruptive behavior and not realize that it's something that they should be bringing to someone's attention or they should be complaining about. You need to deal with it. As we said, you expose yourself to civil lawsuits, perhaps regulatory problems. So it's something that can't be ignored. You have to deal with it. And the key also, I think, is using progressive disciplinary action, starting with collegial intervention. You don't have to go to the nuclear option. Unfortunately, many medical staff bylaws provide nothing. They don't have the policy, and basically it says you have to summarily suspend and then terminate someone. There's no kind of, we call it the nuclear action. There's no, progressive disciplinary process. Now, I know hospitals sometimes have standing or ad hoc committees. One hospital, I guess, inappropriately would refer to it as the bad boy committee. And that's unfortunately because most of the people who went before the committee were male. But that's what happened when these kind of situations arose. They had to come to the committee. It was a small committee, but they had to meet with the committee and discuss it. And it was very effective because it really was a wake-up call for those physicians. And most times it resulted in the behavior being corrected. And then last, you got to take appropriate action. If the behavior and the action is so egregious that it rises to a situation where it probably will adversely affect patient care, you got to take action. One of the most frustrating things or frustrating calls I always get is from a medical staff or a hospital. And they said, well, this doctor did X. It's really bad. We want to punish him, but what can we do up to the point where it won't be a reportable event? And I always tell them that's not the analysis. The analysis is they did something wrong. You think action should be taken. Forget about reporting. What do you think is the right thing to do? And that's really the focus, is what's the right thing to do? And we'll deal with the reporting aspects of it to the National Practitioner Data Bank. Maybe it doesn't reach that, maybe there's alternatives, but the first analysis is what's the right thing to do? Not being caught up with the whole issue of what's reportable. And I think there we go. Alex, I am going to turn this back over to you.
All right, thanks, Todd. So first of our panel discussions, how do we define disruptive behavior? Isn't it too subjective? And Todd, you alluded to this in your discussion, and it's a big issue because we have a hospital that has to, always have foresight with regard to risk management, compliance, and preventing big problems down the road. But we have physicians sometimes who are unfairly targeted. And I'll start with this, which I think, at least from my perspective, has been an issue. You'll have physicians or dentists on the medical staff who people just don't like, right? They say, I can't get along with him or her. They're obnoxious. They're always screaming and yelling. I just hate coming into work with them. And eventually there's complaints and it gets around and it spreads further and further. Leadership of the department and the medical staff in the hospital find out and they start to say, we've got to do something about this. And instead of simply saying, doctor, there's been a problem with the way that you address people, with the way that you practice your civility, your communication. Let's talk about it and let's stick in that subject. Instead, what will often happen, at least what I found, is hospitals will take the fact that they do not like this physician and use that as the starting point, but then go and dig and target them with sort of quality of care issues, which would otherwise have never been brought up, and use that in order to gain that leverage and that threshold they need to report them and possibly remove them from the medical staff. Again, instead of sticking with just the civil communication issues, they're this add-on of, well, let's see how they chart and let's see how they, their quality of care is. And that's a problem I found a lot with some of the clients that I've had.
Yeah, I agree, Alex. And I think defining disruptive behavior is not an easy exercise. There's a lot of material out there to help people guide them in their policies to define it. But I think a lot of times, people struggle with this and it can, and they view it as being too subjective. I always think part of the key is the repetitive nature of the conduct. There's a lot of conduct that's really not acceptable, that kind of crosses the line. But when it's an outlier case, I think the policy has to address the issue of whether it's a recurring pattern of behavior. It can be more easily addressed if it's in that situation. In terms of the subjective nature of it, you're absolutely right. I've seen it countless times. I have two physicians behaving exactly the same way. One guy's in the in crowd, one guy's not in the in crowd. And all of a sudden, they have a big issue with the guy who's not politically connected, not a big producer of business, rubs people the wrong way. where they're tolerating that behavior from the high producer and the one that's politically connected. And I think hospitals have to be very, very careful in that regard when they're doing these, reviews, because that's going to come out if you're targeting a physician in their behavior differently than others engaging in the same behavior.
Well, you make a good point there, Todd. And just to augment that also, I think a hospital has to be careful if they find themselves, at least with regard to purely civility and communication and disruptive issues, targeting the same types of doctors as far as culture, race, or, I mean, listen, sex, we know that the way it is what it is. Male doctors get caught in the net for this type of behavior more than female, although there have been many female physicians and dentists who have as well. But when you find out that you look over the pattern of your discipline for civility and communication issues over the last 2 or 3 years, and you see it seems to be that the people that are getting caught and targeted are of the same race, of the same nationality, the same culture, and that could be an issue. And of course, that could lead to liability and exposure as well.
Good point.
All right, I guess we can go on to panel discussion 2, which is the use of civility and communication courses and programs as remedial measures. This is an important tool that came along around the same time that the language you've described started being included in the bylaws. And I teach for a course in PBI education. It's a program that offers a lot of different course material, remedial courses for healthcare providers in the areas of charting, documentation, prescribing, many other things. But one of the courses given by PBI and other such outlets is in civility and communication. And again, it's never to have a physician come into the course and say, you're a bad person, you have terrible demeanor, we're going to teach you how to be better. It's more, we're going to provide you with a skill set that's really going to help you whenever you encounter problems with other people or you feel that you're going to get into a shouting match. And some of them are simple, right? Some of them is the old 10-second rule, take a breath, step out of the room, whatever it is, get plenty of sleep, get a good breakfast, that type of thing. But some of it's a little more important than that. And it talks about a general way in today's environment, how to communicate with people and get them to see you as a collaborator and not a disruptor. So.
Yeah, I agree. I think the education is so key. We talked about that. And the other thing is that I think we briefly mentioned it earlier, but medical staffs, and they pretty much know this, but it's really a great resource as well as the practitioner assistance program, the PAP program. They will address issues with physicians who have disruptive, behavior issues.
Yep.
I'll let you advance on.
You got it. And this is yours, a good subject.
Okay. Yeah, would it be preferable to deal with disruptive medical staff through hospital HR process rather than the bylaws? This is an involved topic. So let's say you have a physician who engages in kind of abusive behavior towards a nurse. She goes to hospital HR to complain. So the hospital has a legal obligation to effect some type of remedial action and response in a timely manner. If it's an employed doctor, well, then that doctor is subject to the employee policies as well and procedures. But what if it's a private member of the medical staff, just a volunteer member of the medical staff, non-employee of the hospital? So now you have 2 types of potential investigations going on. You've got the HR department that needs to act quickly, and you have the medical staff, because the complaint could go to the medical staff as well, and they have to deal with it. 101% of the time, I can tell you, the HR is going to move quicker than the medical staff. Right. It's just, fact of life. So what do? Do you have 2 processes and investigations going on at the same time? That can result in 2 different recommendations, and that's problematic. So my feeling is that when these kind of things happen, HR and the medical staff have to join forces. There probably should be 1 investigation, but everybody involved, so that there's a unified findings and unified recommendations.
Yeah, I very much agree with that. I like your point about HR and the medical staff joining forces, because otherwise sometimes it becomes very cumbersome and it becomes very confusing, especially for outside counsel, for either healthcare provider, the nurse or the doctor. And let's take an example, because I think that's what you were getting to. Is a nurse and a doctor butting heads in a hospital. The nurse, he's horribly disruptive, and the doctor, no, she is. She never does what she's told, this and that. It goes to HR and it goes to the medical staff because the nurse has complained to the medical staff and the doctor has complained to the director of nursing. It ends up in both avenues. The key here to remember, and especially for outside counsel, is normally, and this is generally, if there is a complaint against an employee of a hospital at the HR level, that usually gets resolved, whether or not they're a licensed practitioner at the HR level. And even if that person ends up one way or another getting moved on from the hospital or quitting because of the kind of environment, it may not get reported. Whereas a member of the medical staff and the process by which the medical staff deals with these things, there's a good chance it's going to be reported permanently, so that wherever that physician or that dentist moves on to, they're going to know about that civility and communication issue because it's going to be in the data bank, or it will have been reported to a licensing board. Whereas a nurse or other ancillary staff, that may not be the case. I mean, if it obviously if it reaches that level of terror, that it does get reported to the nursing board or some other licensing board for that ancillary staff, that's one thing. But normally HR has that advantage that if you are subject to discipline at HR, you leave the hospital one day, hospital number 2 calls, oh, we're checking, we just got an application from this nurse. Yes, we can tell you that she worked here between 2015 and 2024, and that's all they're going to say, because that's by law, that's all you're supposed to say. But reporting with the medical staff is a whole different ballgame. So, all right, we'll go on to panel discussion 4.
Shouldn't we be concerned about the potential for allegations of a disruptive physician to be used to unfairly target providers, and how does one defend against such claims? I think we've kind of touched on this. I mean, it happens, unfortunately. We have the politics of a hospital. You can have a provider. I've seen it where the provider, engages in behavior that amounts to, verbally and physically assaulting a nurse, but they're a very well-liked doctor. They're an incredibly good doctor. They're perhaps in a specialty that there's a shortage of. I mean, they're key to the organization, and hospitals will wring their hands over it. But the problem is you have the same situation with another doctor, and they're immediately out because they're not as important. They're not producing as much volume, and they're not basically in the in crowd, so to speak. So it's hard to defend against those claims. Again, if you have knowledge of the disparate treatment, obviously you can bring that in. But again, it gets down to what's the level of care, and hopefully you have a well-defined policy. What's the level of disruptive behavior that this physician is engaging in? And if it really doesn't rise to a point of a corrective action, then it shouldn't, and you need to defend it. So it's going to depend on those policies. But if they're ignoring it with someone else, and you have that information, I run with it.
Yeah, that's a really good point. That's a really good example, Todd, what you just conveyed there. What I normally do in defending providers against these type of allegations, where I'll see that there's obviously a primarily civility and communication issue at the hospital, and suddenly, oh, and by the way, the little icing on the cake, this quality of care issue we had with you a year and a half ago. And that's when I sort of try to get involved with hospital counsel and say, listen, it looks like what's been going on from a contemporary sense is this physician is not getting along with others there. You feel it's actionable and you want to deal with it. Let's deal with that issue. It's really unfair to start throwing quality of care issues in there for 2 reasons. Number one, you're making it more complicated on yourselves, because now if this goes to a fair hearing and it gets contested, we have to now get possibly experts to deal with the quality of care issue. The medical records are now an issue, right, where they weren't before. So that's more exhibits, more witnesses. Whereas if it's strictly a civility and communication issue, what is going to be the subject of that fair hearing. Dr. X, we think you're a disruptive physician. We're going to present these 7 witnesses who could talk about certain instances and vignettes that have occurred in which you've just been terrible, et cetera, et cetera, et cetera. And that's really where you're going to go exclusively, and that's where you should go. This sort of tag on like these criminal prosecutors do with, they catch you for a burglary or something else, and they say, let's try to dig up 20 or 50 other counts that we can bring to bear here. That's problematic, obviously. So, and that takes us to panel discussion number 5, and that is, should a doctor remain on the medical staff of a hospital where he or she has been the subject of a complaint relating to disruptive behavior? That's a real tough one. I can tell you what advice I normally give providers when they feel, or it's pretty evident, that they are in a toxic environment. But more important, I think much more important, is when they have been targeted. When I feel that they have been targeted, I've always said, and I will tell every provider and every professional in healthcare, normally, because of the political atmosphere that's inherent in healthcare spaces, and especially institutions like hospitals, surgery centers, nursing homes, wherever it is where clinical care is going on. If you have a target on your back, if it's been painted on your back, it's usually going to stay there. So that's something that I warn them about, and tell them to make the very, very hard choice and decision. If you are going to stay, because most physicians who hire us and say, I'm going through this. I've been summarily suspended, and now I'm going through the whole bylaws process through the fair hearing after the MEC, and I'd like to stay in the hospital medical staff. What I'll tell them is, are you sure you want to do that? Because again, if they're looking to get you out, they're going to look to get you out even after they might reinstate you for this one reason. There's a mechanism that Todd is familiar with as well. It's called a last chance agreement, where a physician or a member of the medical staff will be allowed back in the hospital, but under certain conditions, sort of these probationary conditions, which are, for example, if you ever get in another altercation with a staff member or ancillary staff or people of that nature, if you ever become, the subject of another quality of care issue, you have to take as remedial courses, one in civility and communication, one in ethics and things of that nature. Sure, maybe the physician will be able to take all those remedial measures, successfully complete them, never have another issue at the hospital, but that doesn't mean he or she is still not going to be targeted, and that's really important. And what I look upon is the importance of whether somebody's targeted and what to do about that targeting, because it really never goes away, in my opinion. It just does not go away. It can even become worse, which is another issue that I worry about. I've had so often times where a physician will come to me and have a specific problem with communication. I don't hear from them for a year and a half, and I think to myself, well, that looks like that went away and everything's fine. And then, oh, it happened again. They're coming after me for another civility communication issue. And now you have a problem for one primary reason, and this is really where I'm getting at with this. If you have had a civility and communication issue, and now, in spite of that, you've gone through the fair hearing process, and the end result is they've allowed you to re-enter the medical staff and be reinstated after, say, a summary suspension. The good thing possibly to do is to now resign while you are resigning in good standing. In other words, where you're not getting a report to the National Practitioner Data Bank that says, after findings of fact and conclusions at the fair hearing, we have determined that Dr. X is disruptive and he's now being terminated from the medical staff. You don't want that result. You want a result reporting to the data bank, although Dr. X was terminated from the medical staff, he was reinstated and then he resigned, or not even reinstated and resigned, but just reinstated, and then investigation ends, the whole problem ends, and then you resign, not while under investigation, so it does not get reported to the data bank. And that gets to the subject of how the reporting to the data bank and controlling the reporting to the National Practitioner Data Bank throughout this process. That's really, really important. So With regard to should a doctor remain in the medical staff or hospital where he or she has been the subject of a complaint related to disruptive behavior, I think the answer is no. If we think that that doctor is going to be continually targeted, I think that's something you really have to consider and do a close examination and analysis and ask yourself, am I really safe? Has there been a change of leadership at the hospital level? Are the people that have targeted you to begin with, your enemies in the hospital, the medical staff, the leadership, are they still there? And are you still not getting along with them? Have you not reconciled the problem with them? Sometimes you can. Sometimes you, as a physician or a dentist on the medical staff, can say, you know what, I've gone to the Civility and Communication course. I've learned some incredible skills. I think going forward, we're not going to have this problem. Or the individual I've had the problem with has left the medical staff or left the ancillary staff, so there's not an issue anymore. So that's where we are. I guess we can start with any questions that anyone may have in the chat. I'm going to look them up and see what we have. All right, there's some other queries people had, and I know we've had this too in our last talk, or the part one of our series, where people had asked about being and physicians, for example, those representing physicians on the medical staff, where you may have a medical staff issue or medical staff adverse action that's coupled with a licensing board action, and how those two can interface and how you can handle them both at the same time. Those are really good questions, and I just want to address that briefly before we end here. If you have a hospital adverse action that has already been reported to the licensing board, and that can happen in a number of ways. In New Jersey, for example, let's just talk about New Jersey. If there's been a summary suspension that has not yet lasted 30 days, where it will be reported to the National Practitioner Data Bank, but if you have a summary suspension that just occurs, that gets reported to the licensing board. So now you have the New Jersey Licensing Board knowing that there's been a physician suspended through their medical practitioner review panel, that there's been a physician suspended from the medical staff for quality of care issue. So now you got a pending medical board matter that may come to fruition while you're dealing with an adverse action for that client and the medical staff. That's something you have to keep in mind, because a lot of the things that occur during the hospital adverse action are going to be discoverable, and the board's going to hear about it and get it. So now you're preparing not just to defend your physician or dentist before that medical staff privileging matter, but in the future, possibly before the State Board of Medical Examiners, or in New York, the Office of Professional Medical Conduct. So that's something to really keep in mind, that, the action that you're dealing with and you're defending now, keep good hold of that discovery and that strategy, because it might be needed in the future when you face a licensing board and others. Todd, are you still around? Do you want to close?
Again, I want to thank everyone for joining us today for the second part of our webinar series. Hope you found the information helpful. Remember, this is an ongoing series. We invite you to join us for the third part on July 10th, where we're going to be diving into the adverse action reporting and the consequences of a permanent record. If you have any further questions, need additional information, please do not hesitate to reach out to either Alex or myself with the contact information that's been provided. And we're more than happy to help you and assist you as you try to navigate some of these very complex issues. So we didn't get to all the questions, so we will, as we did last time, respond and follow up with the questions to provide you with answers. Thank you once again for your participation, and have a great day. And we look forward to seeing you at our next webinar. Thank you.